I understand the focus is on SGIA, but SGIA and AOSD, there's significant overlap, and most people believe that it's the same disease with differences in onset. There have been a few uh, differences highlighted, with probably minor. According to many cohorts, there may be more females, 2.3 for every one male, while SGI seems to be more one-to-one. And the incidence of ASD thought to be a rare disease, but in my experience, underdiagnosed, was thought to be 0.16 to 0.4 per 100,000 population. The in-hospital mortality is calculated close to 3%, and that's based on a epidemiological study me and my collaborators did, based on big data and a huge Medicare cohort of all hospitalized patients. I'll be speaking more about it later on. So next slide. And of course, we see that there's, well, we don't know the etiology. We understand based on the cytokine profile of patients with SGA and AOSD, that's quite similar actually. There's a pro-inflammatory cytokine cluster with IL-1, interleukin 6, 18, CCL2, 3, 5, 9, and 10. And we understand how it happens, but we don't understand why it happens or what started that, although there are a few theories down the line. Next slide, please. So as you see, and I don't want to spend too much time because other speakers will delve into that in details. Dumps and pumps activate the innate immunity. Macrophages secrete L1 beta or L18. We both have the activation of both the innate and adaptive immune response. And we see that the cytokine burst, familiar cytokines IL-6, 8, 18, and farther interleukin 1. And of course, we have a deficit in the anti-inflammatory path with the Tregs and kappa cells, the S-rages, and interleukin 10, possibly in decrease. So we see have that massive inflammatory response. Next slide. So there have been some retrospective studies looking at the clinical characteristics, comparing SGIA to adult Still's disease. Some of the difference they found was possible, and there may be a report bias, right? Children versus adults, but there seems to be more of a complaints of sore throats, myalgias, weight loss in adults compared with AOSD compared to kids with SGIA. Next slide. And when we look at serologic markers, there may be more uh, increased white cells in adults, also more liver dysfunction based on transaminasemia and GGT compared to adults, to kids. Next slide. Then the articular features in patient SGI, they're similar, but there are some differences. For example, in adults, wrist arthritis seems to be more pronounced, followed by knee and ankle, while in kids, it's sort of the reverse. Ankle arthritis was reported more in this study, followed by knee and then wrist. So those small differences, maybe they're due to the underlying physiology, adult versus kids, or maybe the onset of disease has something to do with that. But it's worth noting. Next slide. So, but other characteristics are very similar. So, for example, the rash, it's almost identical in SGN and Daltons disease. Mostly the torso, we see on the left side, SGA, the typical micropapular rash. We see those lines, scratch lines, and that's the Kebner phenomenon, makes it worse. And while the rash has been classically described non-pruritic, a lot of my patients say, no, it itches quite a bit, and that's where they scratch, and then gets worse. So I encourage them not to do that. Next slide. Interesting, the arthritis is a destructive arthritis, and that's something that's preventable. And I try to emphasize that to to my patients, and I think everybody's sensitized to that. And you see on the left side, you see the difference between on the top panel, what happened in March 2002 versus February 2004. So we see here the top panel, you see maybe some periarticular osteopenia, and obviously that was a SGIA case. While 2 years later, we see destructive arthritis, loss of articular space, ankylosis, and that's preventable with the right treatment. And unfortunately, I see too many cases, even though there's the young adults or post-adolescents that they were misdiagnosed, or there was delay in diagnosis, and they come to me with limited wrist extension, significant arthritis, ankylosis, and irreparable damage. And we wish that we were there early on, with the patients were diagnosed, treated adequately, and we can prevent that, because that will follow them from the rest of their lives. Next slide. Also looking at SGI and LSD, they have similar cytokine profiles, and we see here that they're cytokines like neopterin, IL-18, solid TNF receptor 1 and 2, elevate in active disease. Some of the cytokines will go back to normal when there's remission. In this particular study, IL-18 seemed to be elevated even when there was presumed clinical remission. And there was some hope for IL-18 to be a biomarker maybe for this disease. That study kind of disputes that. Next slide. So looking at diagnostic criteria and classification criteria, mostly. So this is great when for inclusion in studies. Unfortunately, not every patient will meet all the criteria at that time, but maybe sequentially they will. Classically, the Yamaguchi criteria are used more frequently because they have the high sensitivity when compared to other like Jacuzzi's. So we're talking about sensitivity 96% versus 84 for Jacuz, or 81 for Bruno Fotrell's criteria. And all those criteria have strengths and weaknesses. They all based on retrospective studies, and they all use major and minor criteria, so it's a point system. So it can be helpful, and some of the difference could be, for example, Bruno Fotrell's includes some of the serologic markers, where Yamaguchi's like ferritin, glucosylated ferritin, were the traditional Yamaguchi criteria, which is the oldest one, are more clinical. Next slide. One of the, the major problems we have with this disease, and I'm sure it's the same with SGA, is the delay in diagnosis, median 3 to 4 months across studies. But, they have reported more than 20 years. I think that's particularly a problem where the patient may be in the chronic articular phase or have mostly articular disease, and there was a time lag between the systemic findings. So the absence of systemic findings, in my experience, clearly delays diagnosis. And we have all those undifferentiated seronegative polyarticular arthritis that are hard to treat, that a lot of them could be Still's disease. Next slide. So this from a paper I published with Dr. Concias when he was my resident. And we tried to codify in a way our diagnostic thinking for adult Still's disease. Obviously, exclusion of more common diseases like infections, malignancies, and other autoimmune diseases is paramount. That's featured also in the diagnostic and classification criteria discussed before. But there are clinical and laboratory findings that can heighten the suspicion, and in the right context, they can help a prompt diagnosis. Radiographic evaluation is kind of a later finding, not very useful early on, but for established disease can assess damage. And now that we have more sensitive modalities like MRIs and PET-CT scans, they may be helpful even during the active phase of the disease. So I thought that's an evolving pattern, and it helps us since there's not a single diagnostic test that can give us a diagnosis. So it's a clinical diagnosis. It takes experience, it takes knowledge, and a very careful exclusion of other disease states. Next slide. Of course, the MAS is ever fear complication, and like ASIA has been found to be much higher than other uh, inflammatory diseases, up to 12% based on a French study. And since the morbidity mortality is so high, that's something we always look for. And even though we're not able to prevent it with standards for AOSD, I think diagnosis and prompt recognition can be life-saving. Next slide. I mean, we've been talking about the patterns. I think that's evolving too. I think we try to simplify it more as more systemic and articular, and that may help. But you know, traditionally, we were talking about the oligo, articular, the monocyclic, polycyclic, and the chronic articular, and of course, the huge overlap between them. But sometimes it can help us prognosticate. Next slide. I'm going to briefly mention the epidemiological study Dr. Bella Mehta and myself did based on hospitalized records, huge Medicare database, more than 1 million hospitalizations, because there hasn't been a major epidemiological study until when we did that in the US. Helps us kind of see where we are right now with adult onset disease. Next slide. So we found that the patients are hospitalized. I mean, we know it's a disease that starts in young adulthood or adolescents for the adult still disease, but many patients hospitalized are actually older. So we found that the mean age was 53 years. And of course, the majority of the Caucasians. Next slide. But I will show you some differences in how they fared in the hospitalizations. Build that, please. Yes. So we saw that the major inferior complication like MAS in our study was 1.7%, DIC 1.1%, TTP 0.4%, and the death rate was 2.6%, 154 deaths. So looking at those deaths, patients were slightly older, mean age of 62 years old. There was a higher representation of deaths in Asians that didn't fare as well, 14%. Remember, there were only 3% in our overall cohort, but represented 14% of deaths. And we saw that DIC was a major component that led to mortality. Next slide. Again, looking at odds ratio after we adjusted for age, sex, race, and other conditions, we saw Asians were 6.4 times higher risk for death. Every chronic condition added the 20% additional risk, and of course, huge risk. DIC increased the death risk by 30-fold. Next slide. So this summarizes the slide. Small percentage of patients were Asian, but there was overrepresented, unfortunately, in mortality. The overall death rate was 2.6%, and having multiple comorbidities obviously contributed to that. Next slide. So I'm going to briefly touch on treatment, and I know I don't have a lot of time. So, you know, 70s, 80s, and 90s, we use stuff that may have worked, but not really. I would say glucocorticoids may work, but they don't prevent the destructive arthritis. So we try to minimize them even in adults. DMARS methotrexate, you know, I agree with my previous speaker, Dr. Grom. It helps with the arthritis. It does very little for the systemic, and that's the mostly used one. And I think the whole spectrum changed the biologic agents, especially IL-1, IL-6 inhibitors. Next slide.
2 minutes more.
Yes. So again, I touched upon, and in adults, the DMARS is still being used quite a bit, especially methotrexate, but they're rarely effective alone, especially in systemic findings. Next slide. And of course, there was biologics changed. In the beginning, we used a lot of biologics from rheumatoid arthritis. TNF inhibitors may help a little bit, may help more the arthritis. Again, we do relatively little for the systemic findings. Next slide. And aquino obviously made a huge change. Me and my collaborators made the observation that rilonacept also was quite effective in our patient cohort and quite well tolerated, but hasn't been developed really. Next slide. Canakinumab, again, we made the first, Dr. Contis and I made the first observation back in 2012, and of course, the randomized controlled trials SGA confirmed that. Next slide, was recently approved for daltons still disease that helped quite a bit the approval. And there was a study we did, next slide, with within the randomized SGA studies, we identified in blue the what we call young adults, age 16 and 20. All those had SGA, but they behaved physiologically more like adult Still's disease. Next slide, and pharmacokinetics were very similar, and fortunately, the response to treatment was also quite similar as well. Next slide. So this is the therapeutic algorithm I suggested. Please build up in one of my publications. And I think we're getting away from the traditional demarketing steroids. We try to go as early as possible to targeted treatments. First line, interleukin-1, interleukin-6 inhibitors, and other mechanisms are lower. And there's a lot of interest now with the JAK inhibitors, because we do see patients that don't respond necessarily to first or second line treatments. Next slide. Next slide.
Yeah. I don't know what's happening.
I could, okay, so that was my summary conclusion. So basically, we welcome collaboration with pediatric colleagues that are far advanced in both in research and understanding of HAI. I think it's a continuum, and now that our pages age, there needs to be a transition many times. So we greatly need to expand the collaboration and understanding. I think the delay in diagnosis is a major problem and often leads to catastrophic results. And of course, we welcome the new age of biologics that the last 15 years have really changed the trajectory of this disease, and the future is quite bright.
Great. So thank you so much. We have some questions here. I think you just actually talked about JAK inhibitors. You talked about JAK inhibitors. I'm curious, which JAK inhibitors have you been using, and what have you been seeing in relation to that?
Right. So, I mean, the studies, I mean, for example, there's been some relatively large Chinese studies with tofacitinib. I think more than 30 patients with adult Still's disease. I think that's where the most experience is, although I think there is an interest in some of the newer, maybe more specific JAK inhibitors. So I think that's evolving, and I think we'll learn a lot more. Some people think maybe we go to JAK1/2 inhibition, maybe a little better. Very little data. I mean, mostly case reports. But there's also interest, anecdotal, obviously, in combination of maybe biologics, especially the IL-1 inhibitors. They have a very good safety profile and a large therapeutic margin with maybe JAKs, rather signaling inhibitors. So I think we're moving toward that direction, but we desperately need more data.
Got it. So one question is, was thrombocytopenia a risk factor for mortality in adult onset Still's disease, MAS?
Absolutely. So that's one thing I've been teaching my residents and fellows, because typically we see thrombocytosis, increased level of platelet count, that correlates to the systemic inflammation. The minute we see dropping, I tell my residents it's one of the early signs of transition to MAS, because it's also a continuum. One end, the ASD, the other end, the more severe MAS. So when we start seeing a drop in the platelet count, that's a sensitive way to say, well, this patient going to MAS, increase the treatment, maybe if they're hospitalized, transfer to a more monitored setting, because that may signal the beginning of MAS.
Okay. One question is, once you have joint damage in hands, can anything be done to repair the damage?
Well, if there's ankylosis, unfortunately, we can stop from getting worse because it's ongoing. And I recently had a young lady, 19 years old, is a college student, and that damage happened very quickly, within a year or two. Fortunately, we were able to stop it and assist it adequately. I mean, treatment with biologics has been shown. Methotrexate treatment, I think that's a useful one, and sometimes we use it together with biologics, like IL-1 inhibitors, for example, to stop the progression. And we see good results, but unfortunately we cannot do ankylosis and joint space narrowing and loss. But if you preserve enough, especially wrist function, I think the person can be, very functional.
Okay. Have you seen, this is my own question, have you seen any of these patients with PAP like lung disease with clubbing in the hands and foot?
Yeah, I haven't seen a lot of that, but what I've seen, I have several cases, is pulmonary hypertension. That's a fear complication, and that's not very well known, across the board as a risk factor, but it is. And we see patients that develop pulmonary hypertension really severe sometimes. I had a discussion with Dr. Goldman Mansky. She sees that in her patients too. And there are a few publications. I think, I published one of them. There are 5 or 6 cases, but I think it's more widespread. So now we start to understand autoinflammatory syndromes, and adult ciliary SGI is a risk factor for that, especially in the adults, and we monitor for that.